Good morning, everyone, and welcome to Iowa Ideas. This is our ninth year of Iowa Ideas, an event that explores the topics that are important to Iowans, the challenges, the opportunities. We're excited. We're in the halfway stretch of our 2 days of conversations, and so thank you for being here. I'd also like to give a quick thank you to our presenting sponsor, ITC Midwest, for their overall presenting sponsorship of Iowa Ideas. It's what makes this free and accessible to everybody. For those that want to ask a question during today's conversation, you'll be able to submit questions to the panel, entering them into the Q&A box in the Zoom chat, and we will work those into the conversation. I am Zach Kacharski. I'm the executive editor at the Gazette, and this is a session in our healthcare track focused on prescription drugs and price transparency. If that's the conversation that you're intending to hear, you are in the right place. I want to thank the panelists for joining us this morning. We have a great panel with a lot of knowledge, and so I want to have each of them introduce themselves. And so, Wes, I'll start with you. Can you tell us a little bit about yourself?
Yeah, hi, I'm Wes Pilkington. I'm a pharmacist and pharmacy owner at Evans Crossing Pharmacy in Evansville, Iowa. I've been a pharmacist since 2011, and I'm also the current president of the Iowa Pharmacy Association.
All right, Julie.
Hi, I'm Julie Ermy, and I'm an associate professor at the University of Iowa College of Pharmacy, and I study insurance and reimbursement in pharmacy and also prescription drug pricing.
All right, and Mark.
I'm Mark Bloom. I'm managing director of the PBM Accountability Project, which is a coalition broad-based of pharmacies, of unions, of employers, of patient advocacy groups that's very active in trying to make drugs affordable for all Americans, working on legislative solutions at the federal level and in states around the country.
All right. Well, thank you for being here. And, obviously prescription drug prices is a rich topic that can go a lot of different ways. But, in Iowa, there's been recent legislation and kind of wanted to start in the current state of where we are today. And Wes, maybe you could talk a little bit more about, for those that are coming into Evans Crossing, what is life like as a pharmacist today? And, what is the current state?
Yeah, I mean, it's difficult to be an independent pharmacy in this day and age. There have been a lot of closures in Iowa, especially over the last year. I think in 2024, we saw over 30 pharmacies close. We face a lot of challenges, but primarily the biggest challenge that we see is fair reimbursement. So not being reimbursed or paid adequately for the product that we dispense to our patients and customers.
And can you talk a little bit more about that? How does, for maybe the lay person, when somebody comes in with a prescription, how does reimbursement work, and who's paying what?
Sure. So if a patient comes in for a prescription, we will work on filling the prescription, processing it. Technicians will fill the prescription and verify that the product is correct. And then it will come to me and I will verify that the product is correct, the prescription is correct, the directions are correct. And then I will spend time, if it's a new prescription or if it's something I think might have an issue, speaking to the patient about the prescription and warning them about potential side effects and how it could affect their other medications, how to store it. So there's a lot that goes into actually dispensing the prescription. Additionally, when we submit that, when we fill that prescription, we're submitting a claim to a pharmacy benefit manager. And in real time, we can see what the reimbursement will be for that prescription. We don't actually get paid for that prescription until about between 14 and 30 days. It depends on the plan. I would say on average, it's usually 21 days it takes for them to pay us back for the prescription, which we have to pay our bills for those medications that we're dispensing weekly. So there's often a lag time between when we're getting paid and when we're purchasing the product to dispense it.
And I guess, is it a correct assumption or an incorrect assumption that the reimbursement covers the cost of what you've paid for the drug as a pharmacist?
Yeah, no, I mean, it would be an incorrect assumption. Not across the board. Oftentimes we are paid what we paid for the actual product being dispensed. But there are many, many cases. Usually for me, and I'm a small volume pharmacy, I would say probably if I'm filling 200 prescriptions a day, I would say 30 to 50 of those are below my cost to actually purchase the medication.
Wow. And so by how much?
It really depends on the medication. So the higher dollar brand prescriptions, certain plans pay us 1% to 2% below our cost to actually purchase those medications. So it can be anywhere between $30 and $50. I had one yesterday that was for a headache medication, a brand name headache medication for a patient that I lost $58 on. On the generic ones, obviously, it's not going to be as large of a deficit on them because they're lower cost prescriptions. But even in a prescription that cost me $1 to buy, a medication that cost me $1 to buy, if I'm being paid 50 cents for that prescription, the losses are bigger because there's a cost associated with dispensing the prescription.
And maybe this is an obvious question, but do you get to pick which medications that you buy? I mean, and why if you are going to lose, $50 or something on one prescription, why fill or why buy that medication?
Yeah, that's a great question. So if we have the medication in stock, contractually, we are required to dispense that medication to the patient. As far as purchasing goes, if there is a very unique situation where it's a one-off prescription that I would have to order and I'm losing money on it, I probably would make the choice to not order the medication and direct the patient elsewhere. And it's kind of this balancing act that we have to walk the tightrope on, whether or not we decide to dispense entire classes of medication because we are maybe losing money on half of the ones we dispense. So it certainly takes some data analysis to see if it's worth keeping certain things on hand.
Well, and I would think that it's also a question of perception to the customers. If in a town, if you're the source where they can go, if they can't get medication, well, I would think that would be a bad perception to have in the community too.
It definitely is, and it's a hard conversation to have. Generally, my patients know me and trust me and understand that is not. It's not great for me to keep my doors open if I'm losing all kinds of money on the prescription that I dispense to them. So they're generally pretty understanding about it.
Mark, I wanted to ask a little bit. You have a vantage point that's maybe from a national perspective. Can you talk a little bit about PBMs and what do they do?
Sure. Great question, because most folks don't know what they are or what they do. But essentially, PBMs come into existence with a very appealing value proposition. You've got large manufacturers. While drugs are under patent, they have monopolies on their drugs. And then we have individual consumers who have no leverage in that marketplace. By aggregating consumers together, small employer health plans, local governments together, we can amass a volume of demand to balance against manufacturers and negotiate their prices down. So PBMs came in as demand aggregators, group purchasing representatives to bargain down prices. But very early on, after PBMs came into existence about 50 years ago, they began to realize that nobody really understands drug prices. Complex supply chains, many different kinds of prices, that PBMs could act as arbitrageurs, that is, go-betweens in the marketplace that actually make money on the differential between the list price for a drug and the price they actually pay. If you're a representative for a health plan sponsor, for the fiduciary of a plan, the PBM will say, I'm going to negotiate the lowest possible price for you. But the mother of all schemes emerges early on, where PBMs realize we actually go to list prices. We don't negotiate down prices. We negotiate discounts from those prices. And if I can discount a price that's called a rebate and not pass that rebate through to my client, keep part of the rebate and share it with the client, then the PBM is suddenly making money by taking that value they've created by negotiating a discount partially for themselves and only passing part of it through. From that came a whole complex of other kinds of strategies where PBMs were extracting their profits from the difference between the list price and the after discount net price. Understand this, that there are a lot of ways to increase that middle from which PBMs extract their profit. One way is to drive prices higher because there is a greater margin for extracting value. And indeed, over time, lots of evidence has shown that PBMs actually have an interest in bargaining up prices, not bargaining them down, because the profitability, that middle ground from which they can extract value, increases. The PBM market business model has become a model in which PBMs are no longer aligned with their clients. They're not trying to bargain down prices. They're trying to extract value as middlemen in that marketplace. The problem is, if you say, well, then I just won't work with a PBM, I'll buy directly. The problem is you don't have any leverage if you're buying directly. And 3 PBMs actually dominate 80% of the drug marketplace. Chances are, if you're buying drugs with an employer plan, you are one of 3 PBMs that absolutely dominates the marketplace, that processes your drug claims, that actually determines what the price is that will be paid at the counter, and determines what the reimbursement will be to the pharmacy. But we have these giant PBM corporations that sit in the middle of the drug marketplace, arguing that we are representatives for clients driving down prices, but in fact, they are driving up prices in order to increase the value they can extract from the marketplace. That's why in Congress, overwhelming majority, both political parties have reached agreement on needs to reform the PBM marketplace, to realign the interests of PBMs with their clients, and to eliminate those perverse incentives that PBMs have demonstrated in multiple studies, even congressional reports, to prefer higher over lower prices for many drugs in their formularies. So the PBM has emerged now as an arbitrageur, which is extracting what economists call economic rent, value from drug transactions, which don't actually produce any value to consumers.
Well, I wanted to ask a little bit. Obviously, this last legislative session, we saw a bill in Iowa that passed through. I believe that was a multi-year effort, really, to get passage to put some of these terms around PBMs. And so, Wes, can you talk a little bit about where that stands right now? We're in a period of time where the legislation has taken effect for folks that aren't involved in a legal challenge, correct?
Yes, that's correct.
Okay. And Julie, can you talk a little bit about what is the legislation in Iowa? What does it do?
So there's kind of what I think of as 3 main parts to it. So one part is it sets a minimum reimbursement floor for smaller pharmacies. So it sets a minimum reimbursement level on the product side. So what the PBMs are paying for the pharmacists the pharmacies to purchase that drug product. And then it also sets a minimum for what we call the dispensing fee. And those are the costs that the pharmacy incurs for everything else except the drug products. So all the pharmacist and technician time, the rent, the bottles, the computers, everything else that goes on into dispensing a prescription. So it sets minimum payment levels for those, just for the smaller pharmacies. And then it also requires that plans use open pharmacy networks. So they're not allowed to restrict what pharmacy patients can go to, and they're also not allowed to put incentives in place to steer patients toward particular pharmacies. And then the third piece gets back to this transparency. So it puts in place some measures to try and increase the transparency in the contracts between the PBMs and the payers, or the people that hire the PBM. So oftentimes the employers. So it requires that the PBMs pass through 100% of the rebates that Mark had talked about through to the employers. And it also eliminates something that we call spread pricing. So it requires that whatever the PBM is paying the pharmacy for a prescription, that's the same price that they would charge the employer for that prescription.
Okay. So I wanted to ask a little bit about that, the 1068, Wes, when you were describing kind of the time that you take, is that a number that covers the cost to a pharmacist? Do you see that as a starting place? Something is better than nothing, or kind of what is the interpretation there?
Yeah, I mean, a starting place is a great way to phrase it. My cost to dispense medications is higher than $10.68, but many of these claims that are being affected by the legislation and the $10.68 dispensing fee are the ones that I was being paid right around my cost or lower than my cost on. So there will be a benefit to me and every independent pharmacy that is dispensing claims or dispensing prescriptions via those plans.
And Julie, I wanted to ask you, you mentioned small pharmacies. How is that identified? Is that defined in a way that, or maybe rather than the exact legal definition, an idea of how many pharmacies in Iowa?
No, it is. It's defined as, I believe it's less than 20 or more pharmacies in the legislature. Less, so like if they own 20 or more pharmacies, they are not included in that minimum floor reimbursement. So less than 20 so like small chains and independents.
Okay.
Under a common ownership structure. So it is defined.
And Wes, I mean, you mentioned that you're the president of the Pharmacy Association. Do you have an idea of how many pharmacies, or what percentage, or how many fall under small pharmacy?
I don't, but I would say it's the majority of pharmacies in the state. But we've also seen like several chain pharmacies close in the last few years as well. So it kind of is an issue that affects not only the little pharmacies, but also the big pharmacies too.
And I wanted to ask Mark, are these types of legislative, are we seeing more of these at state levels? What does the landscape look like?
Absolutely, we're seeing attempts to reform the prescription drug marketplace in states around the country. In the past year, for example, we saw Arkansas pass legislation which prohibited PBMs from owning pharmacies in a vertically integrated structure that were competing against independent pharmacies of the state, trying to suppress the restraint of competition that was occurring because of that vertical integration. We see states like Colorado, which passed perhaps the most far-reaching reform in the country this past year, in addition to Iowa's. In Colorado, PBMs were prohibited from earning any compensation, any profit, any income from the price of drugs whatsoever. They were restricted only to receiving income from flat dollar fees on services that PBMs provide to their customers to be paid by the customers. So any of the retained rebates, the spread pricing income that my colleagues talked about, fees fees exacted on manufacturers, any kinds of incomes that PBMs earned downstream from purchasing the drug had to be returned to their clients. We'll see that legislation will become effective January of next year. But those are examples of the kinds of reforms that we're seeing around the country. But in addition, numerous states are creating competition between PBMs through passing legislation to create reverse auctions, which basically force transparency on the cost to the state of PBM contracts to state employees, and require PBMs to compete against one another in a digital marketplace, kind of an eBay in reverse, to sell their drugs to states. And some states are considering extending those kinds of marketplaces to the private sector. So there's a variety of different kinds of reforms. It's very clear that the engines of real reform that are being enacted and now tested in courts are coming not from Congress, which has difficulty passing legislation, but is actually happening from states that just can't tolerate the increased costs on drugs and the decline of competition as independent pharmacists, state after state, are being driven out of the marketplace.
And Wes, I wanted to ask a little bit about what made this year different. What got a bill that, I think there's been variations of what was discussed for a while. What made getting it across the finish line this year different?
I think a couple of reasons. One, I think that our legislators really started to understand the urgency. Obviously, those of us in the pharmacy profession understand what a crisis this is, but I think that we did a good job of making sure that our legislators knew what an issue this was, and not only an issue for pharmacy, but an issue for patients, losing their only healthcare provider in their town of residence. But I also think that nationally, these other states that have passed legislation in the past 5 or so years, I think Iowa has seen that and understand that the sky hasn't fallen on those states that have done it. And I think that helped our cause as well.
Julie, I wanted to ask, can you talk a little bit about, what level of transparency PBMs have, and, what makes this legislation an important change?
Sure. So, the level of transparency, a lot of it's going to be determined by that contract between whoever hired the PBM. So I'll just use an example of the employer. So when the employer is choosing PBMs, there's going to be differences in the contracts between different PBMs and the level of transparency. So some PBMs will offer more transparency. So you can have contracts where they pass through 100% of the rebates. You can require no spread pricing. So some PBMs will offer that, others will not. So that's going to just depend on the specific contract. Some areas where it's very difficult to get transparency. So I'll give one example. There are some areas. So one example, so I think increasingly as employers have kind of gotten savvy about the rebates and maybe put in their contracts that they want 100% pass-through of rebates, what we've seen happening is that the PBMs have kind of offloaded some of the rebate negotiation to what we call rebate aggregators or group purchasing organizations who they are affiliated with. And so these companies will negotiate rebates and then take some share of that rebate off the top. And it's very hard to get any transparency around those transactions. So we really don't know from the employer perspective how much of the rebates are kind of being taken off the top. So I think it's very difficult to ever get to kind of a complete transparency in those contracts.
How do you justify, is that not a conflict, of interest if you have that affiliation? How does that pass if the groups are affiliated with each other, isn't that like if Mark and I were colluding?
I mean, we have all kinds of vertical integration industry, as Mark can maybe talk a little bit about this, but we have, I mean, PBMs own pharmacies. Now they're getting into the pharmaceutical manufacturing business with biosimilars. So I don't know, maybe Mark can share a little bit more about that. The FTC has looked into this at different times, but.
And filed suit against the industry in part over the issue of vertical integration, restraint of trade. Let me put it this way. PBMs are not freestanding entities. They were at one time. They were a new innovative business model. The three major PBMs that process 80% of all drug claims in the United States have merged with the three largest insurance companies. So we've got a massive insurance PBM conglomerate. So you're absolutely right. Chasing transparently the cost of drugs or the profitability of drugs becomes a really difficult task because it's bled into integrated insurance companies. The GPOs, the group purchasing organizations, those organizations that Julia is talking about, the three PBMs each own one, some in partnership with others. They aren't affiliated. They are actually owned by the PBM insurance entities. Two of them are offshore in Europe to avoid a regulation and transparency specifically for that reason, and to skim rebates before rebates ever hit customers onshore in the United States. The tentacles and the magnitude of these companies is enormous. And your efforts in Iowa to require minimal transparency when drug pricing veers from NADAC or other benchmarks is admirable, really, really tough. But we're in a marketplace where these gigantic corporate entities that sit in the middle of drug transactions don't give consumers transparency of prices and have the capacity to restrain trade by driving competition, like Iowa independent pharmacists, out of the marketplace at a tune of 20 to 30 per year, to the point where as a independent pharmacies as a business entity will cease to exist at this rate in very short order. That's the power of these entities. If this was Bell Telephone or Standard Oil in a day where antitrust laws were enforced, action would have been taken. The FCC has begun action. And very interestingly, this administration first suspended and then resumed investigations of the industry. It's a real concern. Vertical integration is the name of the game in this industry. We're not talking about a competitive marketplace or a competitive industry at all. We're talking about companies that have the capacity to restrain trade and are actively driving competitors out of the marketplace. In the long run, that's not good for consumers. It's not good for patients.
Wes, I wanted to ask, as a pharmacist, how are these, reimbursement rates set? Do you have say in, what you get in terms of a reimbursement? How often is that happening? How does that process work?
Yeah, I do in some of them. So some PBMs allow direct contracting. And actually, I had a situation this year. I guess I can say their name because they won't return my emails anyway, with Express Scripts. Express Scripts wanted to renegotiate the contract that we had with them that really was probably more fair than most of Express Scripts contracts in the country. And the rate that they wanted to pay me would have been very bad. I would have lost lots of money, especially on brand name medications. We're talking $50 to $100 per brand name medication dispense. So I decided to not sign that contract with them. And I've retained, I would say, 75% of those patients who have found that using my cash program that I have, it's a discount card that we have within our pharmacy. They're paying the same or less for their prescriptions at the pharmacy. They're generics. If they have a brand name medication, they may have to go somewhere else to fill that. Many other contracts are negotiated by groups called PSAOs. So essentially another middleman between pharmacies and PBMs. I believe that stands for Pharmacy Service Administrative Organization. Correct me if I'm wrong. So many of those contracts are negotiated without much of our say. So we're part of a network of pharmacies. And the PSAO will negotiate these contracts on behalf of all of their network pharmacies. And in many cases, the contracts are better because we're part of a big network. But in other cases, it's not necessarily the case. And some of the bigger voices who are members of the PSAO may have more say in what contracts are signed, what contracts are not signed. Some of the PSAOs are actually owned by drug wholesalers who, to be frank, don't really care what a pharmacy is being reimbursed as long as drugs are still being purchased. So there are some issues within that model that have harmed pharmacies and forced pharmacy closures.
I'm curious too. I mean, obviously, then you're negotiating down to the different medications, and so how much time do you spend, kind of, managing that, or understanding?
Yeah, I mean, it's a great question. Last year I had to renegotiate a contract with a plan that had, I think, 150 different like subset contracts. And I had to go one by one and decide which of those networks I wanted to be a part of and not a part of. It's certainly not something I learned about in pharmacy school. No offense, Julie.
I teach that.
Yeah, I'm sure you teach it now. But it just wasn't a thing we had to worry about 15 years ago. But it's very meticulous and something I have had to, in the past 2 years, I've had to spend a great deal of time on, just learning what amount and what numbers I'll be profitable at and which ones I won't, and deciding where I draw the line.
Julie, how does that work? I mean, has that become part of the curriculum, and how do you approach that?
So yeah, I mean, way back when I went to pharmacy school, we talked about pricing. How do you price prescription drugs? Because there wasn't a lot of insurance. Now it's all about reimbursement and how do third parties pay pharmacies, and like what's AWP and what's NADAC and how do those things and how do contracts work? So yes, we do cover that in the curriculum. I mean, you could spend a lot more time on it than what we have. So we kind of cover the main issues. But yeah, we try and make sure that our pharmacy students understand at least the basics of how pharmacies get paid, because that's important.
That's almost a mini business degree right there.
Absolutely. And we teach about pharmaceutical pricing and PBMs and all of that.
It's a mini business degree in how to manage a marketplace that isn't working.
No, it's fascinating. When you're a customer, an end user, I don't think you realize all of the pieces. I've never thought of that, walking in and all of the different pieces, and so I appreciate kind of the detail that you're sharing. I am curious. I know that there's been a lot of conversation about the new law. There were, for employers, there's pending litigation there. Julie, can you talk about, what are the concerns that employers have, or maybe what's driving some of that?
Sure, I can share that perspective. So I sit on the benefits committee for the University of Iowa, so we make recommendations about benefits. So as a self-funded employer, we certainly understand kind of the employer concerns. But I think a couple of main concerns. One is that, if you start paying pharmacies more, that is going to raise the cost of the prescription. And I think the expectation of the employers is that those higher costs are going to be passed through to the employers. I mean, you might say, well, okay, maybe the PBMs would absorb the cost, but we don't. I mean, I think the expectation is that won't happen. We expect that those costs will be passed through to the employers. And so employers are sitting there thinking, hey, our healthcare costs are going up a lot. I mean, there's a lot of concern about how do you provide affordable, comprehensive health insurance benefits for your employees, and prescription drugs are a big piece of that. And so anything that they see as increasing costs is going to be a concern. I think another concern is around having the open pharmacy networks. So just in healthcare in general, one of the main kind of cost containment tools that is used would be closed provider networks, because that allows insurance companies to negotiate lower provider reimbursement rates. And so by requiring open pharmacy networks, it kind of takes away that tool. So employers would have some concerns about that potentially raising costs.
I'd like just to rejoin, because those are such interesting points, because one wonders what exactly the question, why would businesses care? On the first point, if you raise prices, costs, or reimbursements to pharmacists, surely those prices will be paid through if you haven't reformed the drug or the PBM marketplace. If we've got oligopoly, that's virtual monopolies out there without real competition, of course they're not going to absorb those higher costs. They're going to pass them through. You've got to address fair payment to pharmacies in the context of reforming the PBM marketplace so that competition, a competitor will absorb those costs or they'll lose business. A monopolist will not absorb those costs. So you've got to do both concurrently. And this law is, I think, a really important step towards doing that the business community needs to fully appreciate. You can't just do one. They're right. You've got to do both. On the second point about open versus closed networks, it's a really good point that a PBM can negotiate with a closed network in the way they can't unless they own that network. There's no real negotiation going on with the closed network if the PBM owns the pharmacies in that network. It's just setting the prices all around. So we can't naively dance in here assuming there's a competitive marketplace that works like other competitive marketplaces do. It's not a competitive marketplace.
Right. And I would agree that there are conflict of interest concerns in the pharmacy arena that we don't see in some of the other closed networks. So I'm just saying the business's perspective is that you're kind of taking away a tool that we use. So
great. I agree.
Well, and it's unique with the University of Iowa too, because obviously they have pharmacies, and wanting their employees to go to their pharmacies makes a great deal of sense. But that isn't, I don't think, the issue somebody like me is looking at. I would totally understand if a health system would want their employees to use the health system pharmacies. And one piece I think is being missed in this is, we're just looking at that dispensing fee and saying we have this many prescriptions, times the dispensing fee, that's how much our costs are going to increase. But if there's no spread pricing, which PBMs in an ideal world would act with pass-through pricing, meaning you're charged what I'm paid, but that we know that that's not how it works, and that I'm paid one thing and you're charged something greater than that, and they keep the amount in the middle. If employers are now seeing that amount in the middle disappear, I would expect that dispensing fee to be offset and more.
So I think it's going to depend on the contract that the employer would have with the PBM. I mean, I certainly am in favor of pass-through pricing. I really like the NADAC plus dispensing fee model, because I think at least you can look up NADAC and see what it is. So I think it's hard to audit the other, even if you have audit rights as an employer, it is hard to know what the pharmacies are being paid. Whereas NADAC, you can look up and say, okay, pharmacies are being paid NADAC. I'm supposed to be charged NADAC. I can look up NADAC and see what it is. So I do think it's a fair model in the long run. But I do think, the employer perspective is they're looking at, hey, the dispensing fees were sometimes 50 cents or $1 before, and now it's going to be $10.68. And so they're thinking, wow, that's going to really increase their costs. So that's kind of the employer perspective.
Yeah, absolutely. And what I've seen in my experience so far, this law being enacted, if someone hasn't met their out-of-pocket, employers have just passed that dispensing fee on to the patient, which is pretty unfortunate, because I don't know about any of you, but my premiums have not gone down ever from year to year. So if we're expecting premiums to increase and making the patient pay more at the pharmacy, it seems pretty unfair for the patient.
Well, I'd like to certainly say I haven't had mine go down either, but I want to just contrast that with the case of New Jersey. A few years ago, we designed a reverse auction, as I described earlier, for PBMs. and force PBMs to compete to sell prescriptions to the state public employee plan. And the cost of prescription drugs, because the major PBMs were forced to compete, fell by 20%, which in New Jersey turned out to be $1.6 billion in savings to the state. With that, the state reduced overall healthcare premiums for the first time in modern history to their employees, and actually balanced the state budget out of Express Scripts profits that were saved through the reverse auction. So it's possible. Hang in there. It's possible.
One of the clarifying questions that I wanted to ask, you say NADAC. Could someone explain, just for maybe viewers that don't know what that is?
Sure, I can take a stab at that. So there's actually a survey that's done, a federal survey that goes out and surveys pharmacies about how much it costs them to buy a drug. So it's the National Average Drug Acquisition Cost survey. So it's kind of to get a sense of nationally, kind of just across the country, how much does it cost pharmacies to buy drugs? And that is publicly available. So you can go on to a website on the Centers for Medicare and Medicaid Services, and you can actually look it up, and it's updated regularly. So it's kind of a neutral cost estimate that's out there. Now, it doesn't mean that like Wes's pharmacy can buy drugs at exactly that price, right? Because pharmacies are going to have different buying terms. But it's one measure that kind of gets at what pharmacies are buying drugs at. And it's going to be much more accurate than AWP, which is kind of the sticker list price that is often used now, which is gamed extensively. And so that's why I prefer that as a reimbursement method.
I also wanted to just ask, with the concern about this, is there concern that with this change and seeing maybe the service fee, that PBM organizations would kind of say, well, see, this isn't working, your prices went up. How do you prevent against that, Mark? Is this something that's been seen in other states, or how do you educate consumers so that maybe they dig deeper in terms of understanding the service fee or that increase?
The increase, the problem about educating consumers about how this marketplace works and how to justify fees that are throughout the marketplace, manufacturers' fees, pharmacists' fees, other supply chain actors' fees, is that's a steep road to climb. I think it's reasonable to demand transparency. That is, how much is my drug costing through my plan, my PBM plan? PBMs set the prices of drugs in each plan. We have to understand that. Nobody else is setting those prices. PBMs are setting those prices. What's that cost? For the pharmacist, if he has an opportunity to sell that drug, not on the plan, but in another way that could be more affordable, for the pharmacist to have no gags, to be able to transparently present prices, not only speaking to the patient at the counter, but online, on site, for patients to be able to actually see what the alternative prices of drugs are in their plan and outside of their plan. That's what consumers ultimately want to do. When I buy a car, I don't need to know how the car works, how the engine works. I need to know the qualities of the car I want to buy and what competitive cars with the same qualities cost. That's all I need to know to make a rational decision. Mm-hmm. Consumers currently don't have that information in front of them. And the idea that they could, and Iowa has made an important step in this legislation towards giving them that information. That's the information they need. What does this cost me? And Wes, for you to be able to say, here's what the drug is costing me, here's what I'm charging for it, this is what I'm being reimbursed, this is the fee I'm being paid for the service, that great service. In many towns, maybe in your town, you are the primary care provider. You're the one who's telling the patient how to use the drug, what side effects they maybe encounter, and what to do if they encounter those drugs. What is your service? What is the fee you're being paid for providing those services. I think it's important for people to understand that and for you to be able to tell people that. And in fact, for that to be posted. So transparency is really good. And it should be transparency that matters. And for consumers, it's what the cost is to them. That's what matters, and what the alternatives are to them.
Yeah, and if I may use it in my pharmacy using this cash-based program that we use, I actually have a Medicare plan that we did not contract with that offers no premium. So many people who have low-cost medication signed up for that Medicare plan and decided to stay using my pharmacy, even though we're not a network for it. So what I was able to do is just say, hey, this is the cost of your medication. This is what our dispensing fee is. This covers our cost to dispense it to you. This covers the cost of me telling you about it and making sure everything's going well. And people are so receptive about that. I just can't stress that enough. People are so willing to pay that fee, knowing that they'll have me there to be able to help them whenever
you'll be there, and they know what the cost of the service you provide them is. That really matters to people in the marketplace. Yeah. Another way to look at it is, if there's a line of people waiting at your counter, Wes, each one of them with a different health plan is paying a different price for the same drug at the time that you get it. If we could step back and tell consumers, what are you paying? What are you paying? You're filling the same prescription from Wes, from the same pharmacy, and it's all different. It'll blow people's minds to understand that. So if you're a plan sponsor, a small employer, for example, in the state of Iowa, and wouldn't you want the same information? What am I paying for the drugs in my formulary? And what are other small employers paying for the same drugs? Again, their minds will be blown to see everybody's paying different amounts. In a competitive market, you're falling to an equilibrium price. Everybody's paying the same price. That's where we want to get. Enough transparency so that if people are paying too much, they'll stop paying and go somewhere else. That information is not available in the current marketplace. The law you and your legislators passed is at least a first step towards making that information available. People will benefit.
Wes, I wanted to ask, just, can you share a little bit about, as you watch folks come into your pharmacy, how much time are you spending, and what is the expectation that they have, that you're a navigator to help them understand the pricing? How much time do you spend, and what does that feel like to have to? I mean, you're essentially the face for somebody that's making a choice. Can I afford this? And what does that feel like?
Well, it is a difficult thing to explain sometimes to people.
We're 40 minutes in on this conversation, and it's very complex.
Yeah, it's very complex. But I would say, especially at the first of the year, every year, I spend a great deal of time having conversations with people about it. I mean, their expectation is that they can come in and talk to me whenever they want, which is part of the reason I'm in business. I'm able to have that face-to-face with them. I'm able to give them that honesty, and they trust me because of that honesty. And we have that conversation a lot. Why does my medication cost this much? Is there anything we can do to lower the price of this medication? And it's not an enjoyable conversation in many cases to have, especially when people are having to choose between getting a medication and going to the grocery store that week, which is a situation that we run into a lot.
I wanted to also ask, and maybe this is to Mark, but obviously it sounds like when this legislative change is put in place, it's going to take a while to fully understand how well it's working. And so it's not immediate. Some of these contracts have to come up for renewal. What is the length of time that folks should, be thinking about that it could take to fully understand, the impacts that the bill or the legislation has?
I'm gonna punt this a little bit to Julie, because I think she'll have a better understanding of the local marketplace in Iowa. I just want to say that PBMs are remarkably creative about creating new arbitrageur tricks, scams, because remember, they're trying to take the money out of the middle. Um, when people began to understand that you're retaining rebates and requiring they be passed through, PBMs started assessing fees to manufacturers, to wholesalers. They began going at spread pricing after pharmacists and clawbacks from pharmacists. We'll reimburse you this much if you meet thresholds. You don't meet those thresholds, we're taking the money back. They're infinitely creative. And so we're going to have to not only see whether this works, but we've got to have a radar out for the new arbitrageur middleman scams by which value will be extracted. Ultimately, the ultimate solution, and we'll see it pretty quickly, is if we basically say what Colorado has just said, no, you can't make any money off the price of drugs. People should pay what the drugs cost and pharmacists be reimbursed fairly. You can't make any money from that. What you can make money is for selling us services. Services like negotiating the drug, like clinical review studies, processing claims, all those services in place, not a percent, because a percent's a perverse incentive to want a higher price. Pay us a flat dollar fee for those amounts. When we get to that kind of a market, we'll see real results quickly. But right now, Julie, what do you think? How long do you think it would take for law to start to be felt in the market?
So I think, we're already starting to see some of the higher payments to pharmacies go through for some payers that are not, where we don't have the injunction with the lawsuits. So I think for pharmacies, they should start to see at least a little bit of relief immediately on that side of it. In terms of the transparency, like I totally agree with what you said. I describe it to my students as like the arcade game of whack-a-mole, where something else is going to pop up, and so that's where I'm a little bit cautious about saying like, oh yeah, we're going to see these big savings on the employer side from the transparency, because I do suspect that we're just going to see other types of fees and things that pop up, because as you said, the fundamental problem is we have three big PBMs that really dominate the market, and there's so much complexity in the market. It is really hard to get to a truly transparent system. So we'll see.
I wanted to shift gears maybe a little and zoom out a bit, but Medicare has been allowed to negotiate prices, and I think that comes into play in 2026. And so is this going to, what impact do you think this is going to have on PBMs? Does it reduce the need? Or is it only because there are a limited number of drugs that it's going to limit the impact? What do you think there?
I just opine very briefly that Part D and Part D, these are still PBM plans. And PBMs, one of the tools they use is to decide what drugs are on their formularies and what are not on their formularies, or what are on the preferred tiers of their formularies. So as long as the Part D plans leave PBMs the freedom to design profit maximizing formularies, they'll have a very potent tool for muting the impact of direct negotiations with the federal government between manufacturers and the government.
So
I'll stop there, but Julia, you may have some insight.
yeah, I in a sense, I would like to see more movement away from the behind the scenes rebate negotiation toward more of a lowered list price strategy, because I do think, if you look at one of the things that the PBMs do, that's that rebate negotiation, and that's what makes it harder for other organizations to kind of break into that oligopoly. So I think if we had a system of negotiated lower list prices rather than a behind the scenes rebate negotiation, that would more easily lead to a more transparent market. So from that standpoint, I think, well, at least it's a little bit of a step in that direction. Now, Mark is right. There are all kinds of things you can do with benefit design and cost sharing and things like that. In fact, I've got a little project going on now with some of the PharmD students to actually look at how the patient cost sharing for the first 10 drugs that are being price negotiated is changing from our current year, and then what it's going to look like in 2026, just to see what changes are happening for those drugs. So we'll see.
If I may, quick, Zach, those drugs, unfortunately, the bill for that price discrepancy between what the price of the medication is for the pharmacies and what the government is paying. So say I have to spend $300 on a bottle of something and I'm only being paid $150 for it. The manufacturer then has 60 days to pay me that difference. So I'm essentially my little tiny pharmacy having to foot the bill here for these Fortune 10 companies who certainly could be doing this themselves. It is going to cause major cash flow disruptions for independent pharmacies. I've mentioned before, I'm a smaller pharmacy. My PSA told me I need to have at least $20,000 extra in cash for the first quarter to be able to front the bill for these drugs that the prices are lowered on. And I think that's a major problem with this program. Additionally, I think it's kind of like putting a Band-Aid on a bullet wound. Rather than trying to determine why prices are so high, we continue to just mandate that the price can only be so high, instead of trying to fix the problem in our country with why they are so high.
Yeah, I would say it's really unfortunate that they're really putting that onus on the pharmacies to wait for that payment. It could have been structured a different way. I was really disappointed that they set it up that way.
Well, and is there discussion yet about changing that, or is that going to be kind of another learning experience that individual pharmacies are going to have to educate through?
Yeah, there's been massive advocacy from the national pharmacy groups to not structure it that way. Unfortunately, the national pharmacy groups aren't who the government is worried about keeping happy.
Yep. Okay. That's it's extremely complex. That's a whole nother layer on what's already been a complex conversation here. I am curious, are there other policy ideas? Mark, you kind of have the landscape, that folks are trying in terms of where we go from here. Obviously, Iowa has made an initial step with new legislation. Are there others that should be on the menu for consideration?
Yeah, I alluded earlier. Well, in the winter, last December, there was a package which remarkably was approved by Democratic and Republican caucuses of both the House and the Senate for historically the most far-reaching drug marketplace reform ever. It would essentially have prohibited PBMs from earning income that was tied to list price of drugs, wherein they have an incentive for higher list prices because their income streams increase. It would also, in some of the early versions of the law, would have prohibited PBMs from earning any income except for reimbursement for services. So a law that was ultimately enacted in Colorado this year. It's remarkable that that's one of the only issues that has bipartisan support on Capitol Hill today, even in the midst of the government shutdown. There is general recognition that we have to do something about the cost of drugs and that we have bipartisan agreement on moving forward that legislation. So one of the things to look at, I can't comment on I won't comment on the general political environment and the tribalism going on between the two parties. Hard to get people to talk about getting to yes on anything, but this is the issue. which I think is most promising, for Congress to reach a bipartisan agreement on, because they already have last year. It was guttered, but folks still want to get it done. The other issue that's starting to be discussed at the federal level is the GPO issue, the issue that there's growing recognition that PBMs have these group purchasing organizations that Julie referred to earlier, that are actually owned by the PBMs, were created by the PBMs since 2020, as people started to get onto the you're retaining the rebate game. These were created by PBMs. Members of Congress understand that. It's an educational process always, but I expect we'll be seeing legislation that will require transparency of and other potential limitations on the PBM use of GPOs. But again, as long as you're playing that whack-a-mole game that Julie described, trying to attack the latest abuse of PBMs by PBMs of consumers, they'll always be creating them more rapidly than legislators can prohibit the old ones. We really have to look at a paradigm where the PBM business model is recognized to be anti-competitive and must be substituted by a model in which PBMs are paid for the service that they provide, for acting as agents for fiduciaries, for plan sponsors. Negotiate down the price of drugs. Don't negotiate discounts from a high price, as Julie said. Let's get into negotiating prices themselves and passing through those reduced prices like any fiduciary must to your clients. When we get to that kind of a marketplace, it can work again in favor of pharmacists and of consumers. So that's still a little ways off, but folks like Buddy Carter, a pharmacist in Congress from Alabama, folks like pharmacists and others in Colorado actually are moving legislation to do that, to eliminate the right to earn profit off the price of drugs and focus on PBMs providing services. That's the direction we have to look for, a long-run solution to this problem. Iowa's beginning to move in that direction as well. Final thing I'll say is DOL, Department of Labor, that oversees ERISA, which is violations of ERISA preemption over state law, is what the TRO is about in Iowa right now. DOL is actually looking actively at having a broader, more expansive interpretation of DOL's rights to regulate PBMs than it's ever had in the past. The Trump administration, if nothing else, is expanding the prerogative of the executive branch to act in the marketplace. And this is one that could actually benefit consumers and benefit pharmacies.
All right. Well, I know that we've reached the end, actually gone a couple minutes past the end of the time this morning. And so I want to say thank you to Mark, to Wes, to Julie for taking time. Fascinating, complex conversation. And so thank you for each of your time and for your work and knowledge and sharing that with our audience. I appreciate it. Thank you very much.
Thank you.
Thank you.
For others, folks with Iowa Ideas, we will be jumping. The next session starts at 10:45. So if you want to jump to the next room, it is time to do that. So thank you very much.